Good morning, dear chairs, dear audience. I would like to talk to you about my PhD topic, the role of mental health status in pediatric inflammatory bowel disease. First, I would like to summarize the progress of my first project. Pediatric patients with inflammatory bowel disease are 50% increased risk of depression. This mental health issue is not only associated with poorer patient-reported outcomes, but also contributes to a greater disease burden. For pediatric gastroenterologists, enhancing quality of life of the patients is one of the primary therapeutic endpoints. However, effectively addressing comorbid depression is a critical, yet often unmet need in the holistic care of these patients. Our analysis indicates that proper psychological interventions can effectively decrease the severity of depression in those who already have depression. This emphasizes the necessity for early identification and the timely psychological support. I'm a pediatric gastroenterologist at Bethesda Children's Hospital and a first-year PhD student at Semmelweis University. And with my group, our aim is to improve the life and the care of pediatric IBD patients. We have two projects started in autumn. I would like to start with the first project, which is to investigate the effect of psychological interventions on disease activity and quality of life of pediatric IBD patients. It is done by a systematic review and a meta-analysis. We know that 25% of IBD cases are diagnosed in children and adolescents, and it is important because these years are crucial for developmental, for psychosocial growth and from development. And we know from studies that pediatric onset IBD patients are 50% increased risk of developing depression, and other disabilities also more prevalent in this population. So, however, current guidelines focuses on medical and nutritional therapy, but lack of psychological recommendations. Psychological interventions can have a positive effect in several ways, and our aim is to understand the impact of them on disease activity and quality of life. Our clinical question were that does clinical intervention, psychological interventions change the disease activity and quality of life of pediatric IBD patients compared to standard care? We put it in the PICO framework, and our outcomes are clinical and psychological scales and scores, and our hypothesis that psychological interventions increase the quality of life and decrease the disease activity. We performed a systematic research in 3 databases and found about 9,000 articles, and after the selection process we had 18, and currently we are facing ahead of grade assessment. In the following slides I would like to show you our results. All of our studies are randomized controlled trials, and in each figure, where in each article where they use different scales, for example, health-related quality of life, depression and anxiety, we transform that with the help of statisticians to a common scale, and the effect measure is the difference of mean differences. On the first figure, you can see the children's global assessment scale. It's a 0 to 100 scale. The higher number means better quality of life. And as you can see, we have 3 studies here. The patient's number is above 200, and with the psychological interventions, the health-related quality of life score increases with 4.97, which is not clinically and not mathematically significant, but we can see the tendency is promising. On the second slide, you can see the disease-specific quality of life score, impact-3 score, which is important because it shows more information about the disease burden than the biological markers and clinical markers. Here we have 4 studies, and the patient number is 230. And as you can see, with psychological interventions, the impact 3 scores improves with 2.8, which is mathematically significant, but we can say that clinically it's not a significant increase, but for the reason that we say that the psychological interventions should be improved. On the third slide, you can see the depression scores. In that case, the higher number means more severe depression symptoms. In that case, they use the Child Depression Inventory, which is a 0 to 54 score. And we made a subgroup analysis based on one outlier article. And we found that in the first article, those patients had clinical significant depressive symptoms. And that's why we see that with psychological interventions in the Child Depression Inventory, scale is more, it improved more than the others. On the fourth score, you can see the anxiety scores after 3 months of psychological interventions, and we have 3 articles here with a patient number of 230, and we saw that psychological interventions in these patients didn't improve or decrease the anxiety scores. The strengths of our studies, that all the studies are randomized control trials. The population is homogeneous, meaning that all the patients are pediatric patients with inactive disease, but the limitations that the sample size, and in some articles they use multiple scoring systems, and the interventions are heterogeneous. All of them were psychological interventions, but in the length, the intensity, and the nature, they were heterogeneous. For the conclusion, we can say that psychological interventions might improve quality of life in patients with inactive disease, and cognitive behavior therapy decrease depression severity in patients, in pediatric IBD patients with clinical depression, which is an implication for practice that the early identification of patients with depression is important, and it's also important to choose an appropriate psychological intervention. And for further research, more studies will be needed. And the effect of hypnotherapy should be also searched. To say some words about my second project, it will be a prospective observational study investigating the effect of depression and anxiety on disease activity in newly diagnosed pediatric IBD patients. We can see mainly from adult studies that mood disorders and anxiety has negative effect on disease curves. Patients with these issues had more severe clinical course and complicated disease course, but our aim is to investigate that in pediatric population. And for that, our clinical question is that does initial mental health status affect the clinical course of pediatric IBD? Our patients will be newly diagnosed pediatric IBD patients, and we will examine also their mood and anxiety status, and after that the progression. And our hypothesis is that the mood and anxiety disorders affect the clinical course negatively in pediatric IBD, and if it's true, we would highlight the importance of initial psychosocial screening and the early importance of early intervention. For summary, for our first project, we plan to finish it in this autumn, and for our second study, we plan to finish it in next year. I would like to thank you for your attention with a quote from Maimonides: "The physician should not treat the disease, but the patient who is suffering from it." Thank you for your attention.
In the first project, you mentioned that patients would, as an implication for practice, that patients would need a more individualized approach for psychological interventions. Could you please elaborate on that?
Yes. We found that, as I mentioned, in the articles, they used different type of psychological interventions because it's a broad spectrum, and from these studies, but we couldn't do a subgroup analysis, we see that the patients with depression, for them, the cognitive behavior therapy was good, and the patients who didn't have depression, but the quality of life improved, the hypnotherapy was good. So it means that first it's very important to screen that if there has a higher level of depression or other psychological disorders, but if they don't have, it's also worth to try to improve the quality of life of them, some of the interventions, but we are lack of data regarding that.
I was wondering, you were talking just about the scores regarding the anxiety, the depression, but what about the activity score of the disease? Did you have data in the articles to analyze that?
Yes, we plan to analyze that in the systematic review part because we didn't have enough data to do the meta-analysis based on the activity scores.
I have a question about the age groups of the patients for the first project, because depression for a 7-year-old and a 17-year-old can be quite different, in my opinion, but I'm just curious what you saw in your data.
Yes, we saw our population is, we can say also 7-year-old children are included, but from the articles we see that depression is much more prevalent in adolescents and young adults. So they are, as I remember, the youngest patient were 10 years old. So yes, we can see that pediatric IBD patients, or among pediatric IBD patients, the depression is more prevalent in the older population, but in pediatric population, yes.
I had a question. You as a clinician, which psychological intervention would you recommend for clinicians to use based on your results?
First, I would screen the patients because it's a basic of them, and maybe I would recommend, if we talk about all the patients, that it's good to not just to take the pills and modify a diet if it's necessary, but to encourage them to do physical activity and other activities which could be a prevention for depression. And if they have signs of depression, I would ask our psychologist to help to diagnose them, and yes, it would be the psychological or psychiatric decision which will be the more helpful for them.
One technical aspect, if possible. In your second figure, I noticed there was the last study which had low weight, high magnitude of effect, and very wide confidence interval. Does that study, is it really relevant, and does omitting this study change the statistical significance of your result?
No, it was, as you can see, it's a very low patient number. It is data from a study which included mainly adults, and we do a live-on-out analysis, but we didn't see any effect if we omit that. So we stated here.
Is there any particular reason why you did not include adult patients? So here, your current question is the beneficial effect of psychological intervention generally in IBD patients or only in pediatric patients, because, for example, the beneficial effect is already established and supported by the societies in adult care. So I'm just wondering, because if you want to investigate generally the psychological tools or interventions in IBD, then maybe you could have include adult patients as well.
Our focus is on pediatric population because as in the guidelines it's not so prevalent in the pediatric.
And in the adult care?
I think to apply specific psychological interventions is nor in the recommendations. No. So, but they have some data, and when we did the Prospero registration, we found that they did in adults, and they are good studies, but beside that fact, they didn't change. But we want to focus on pediatric population because, as in the exclusive enteral nutrition, which is a therapy for Crohn's disease, we see that the pediatricians could make difference or could make change in also the adults' care. So we hope that with this fact, we can say that we have to reason why to change the practice.